All right, it is noon. We want to start this thing on time and get done on time. So, welcome to our monthly CME presentation, which we're going to try to do monthly. This is our second go around, and our first go around we talked about basically bioidentical hormones 101. And based on feedback, what some people would have liked to see is a stepwise approach to evaluating hormone-related disorders, including a screening tool. And so we have met your requests, and hopefully you're listening in and you'll get something out of this. After today's session, I am hoping that you will be able to, in your clinical practice, be able to screen and evaluate hormone-related disorders. That's the whole objective of this presentation. So I am Shawn Needham, and I do own Moses Lake Professional Pharmacy, and Karl Lambert, ARNP, will be on the line again, and he is going to be presenting most of the time. I'm just kind of doing an introduction and going through some of the first slides to show you some of the details and objectives about what we'll be doing. You will get one CME credit for this presentation. So if you do listen in, make sure you let Lindsay know. Lindsay's been in contact with most of you, and she is taking care of all the administrative tasks. And thank you so much, Lindsay, for that. A lot of work goes on behind the scenes to set this up. So I really, really appreciate it. And like I said, we're hoping to continue these. We're not going to do them in the summer. So June, July, and August, we will be absent. But stay tuned in September, because we're hopefully going to have another session in September. So that being said, make sure you give us feedback of future topics you would like to hear, maybe more specifics about certain specific hormones, or maybe something non-hormone related. We would love to hear your feedback, and we do listen to them. That's why we're doing this one today, is because of feedback from a viewer. So we really appreciate it. So let's go ahead and get started. And go ahead and one more slide. The objective is how to use a screening tool. Karl shared with me his screening tool. We're going to be going over that here shortly. It's really, really cool. Great way to educate patients for sure. And what does the first visit look like when you're evaluating hormones? Which laboratory tests are appropriate? And optimal versus normal laboratory values. You'll hear that a lot when it comes to hormone replacement. Optimal versus normal. And not just hormone replacement, but I'm a big believer in that period. Labs are just a tool to go along with symptoms and history. So optimal is very, 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 very important versus normal. Because what is normal? Sometimes when we look at normal labs, those lab levels were based on sick patients. Not optimal feeling patients. So let's remember that. So what does initial laboratory review look like? And then what's the appropriate time for follow-up? Screening tool. This is a really, really cool screening tool that Karl shared with me. Karl is the CEO, president of RediMedi Clinic in East Wenatchee. And we've been working with him for many years. And I appreciate Karl's expertise, and just love working with Karl, and his patients just say so many good things about him. So thank you for being on the presentation today, Karl. So here is, when you log into this, it's called simplehormones.com, and it's free for patients, and providers pay for it. And I'll let Karl talk a little bit more about that, but you pay for this service like annually or something, and then you give the patients a login. And this is a great way. There's one on menopause, and there's one on males, and there's the menopause one right there. So there's little quick videos to educate patients about these different issues. Go ahead and go back to the male one, Lindsay. And if you look at some of these, these are things that Karl and I talk to our patients about, all the time. If you look down to the module 2, testing normal versus optimal levels of testosterone, those are just things we hit home all the time. So to have a video where patients can reference that is a great opportunity. Same thing with going to the menopause one. If you look at some of these, the root problem of menopause, we talk constantly to our patients about fixing problems to the treating symptoms. Hot flashes are just a symptom of deficient hormones. So, fix the hormones and you fix a lot of other problems. There's some other things in there. I like the one, if you remember from the presentation a month ago when I talked about Premarin, there's a little video on there about Premarin, and it says hormones from horse pee, disgusting. And like I said, I am not politically correct about it anymore. I used to be a little bit nicer about it, but I just call Premarin what it is. So, lots of good videos like that. So, Karl, do you have anything to add about what's been your experience with this little module?
I probably have been using it for my patients, for the last at least a year, and it's made a huge difference whether I give it to the link to patients either before they come in to see me or after I've spent time with them, educating them, and I say, okay, now we're going to get labs, but I'm going to send you this link. And most men and women come back on, wow, those really answered a lot of questions or confirmed what you had already said. So it's been a really helpful tool, and it's really cut down on a lot of questions, a lot of my time, and it just gives folks kind of the confidence to move forward.
Yeah, I think one of the things that's really important with hormone replacement is there's so much misinformation out there, I believe, that it's important to give the patient great information so they can make educated decisions based on what the clinician says and based on other educational tools. So I appreciate you sharing that with us today, Karl.
Yeah, you're welcome.
So go ahead and go to the next slide, Lindsay. I think we're going to really focus on case studies today. But here's some of the symptoms that Karl would look for in his office, and in our pharmacy when we are referring patients, we refer a lot of patients Karl's way since he is a hormone expert. These are some symptoms that we will get when females call in, and probably the number one symptom, maybe not number one, but a very, very common one is hot flashes. That's a very, very common one. And the great thing about that is those are pretty easy to fix usually. But weight gain, insomnia, moody, fatigue, decreased libido, high cholesterol, history of thyroid cancer, all these are symptoms of hormone deficiencies. So when you think high cholesterol, my point is and I hit this home last time, but I want to reiterate this. When you see a patient, especially in their mid 40s, male or female, they have high cholesterol, don't think Lipitor, think hormones. Karl, what do you have to add to this slide?
I would, actually there's a case study I would have loved to have added, kind of honing in on that point of high cholesterol and the benefits of hormones in lowering those. It just is, it's fun to watch it, see it actually in clinical practice.
And speaking of that, not tomorrow, we have a Thursday podcast, Health Solutions with Shawn and Janet Needham. And this is not an advertisement for it, but we're just talking about cholesterol. So not tomorrow, but the next Thursday, I am going to be discussing cholesterol and if cholesterol is bad. So, tune into that. We can give you some information about that too, because it's going to be a good one. It's going to be controversial because so many patients are on high cholesterol medications, but I'm not sure cholesterol is the problem. Do you have anything else to add to this slide about symptoms with females, Karl?
Oh, I would just say, again, that it's a beauty to watch, especially, the females have a lot of those things change, not dramatically. It's over the course of several weeks, several months that you start to see them, lose those hot flashes. That happens pretty quickly, but to lose the weight, to sleep better, to feel better, that's just a tremendous benefit.
It is, and it's so inspiring, and I just love seeing patients get better and fixing their problems rather than just treating symptoms. And we have fixed so many patients with hormones, and that's why I have such a big passion for it, because patients just are so grateful for things they've been going to the doctor for years, and they've said it's all in their head. And then, we finally get their hormones balanced and they feel so much better. Can you hit a little bit on the history of thyroid disease, Karl? That's kind of I don't ask that question a lot. So can you hit a little bit on that one, Karl?
Well, thyroid, when it comes to thyroid, and this is a common complaint I hear from so many females, not so many men, but females, they come in and they go, I've been to the doctor. They always tell me my labs are, if we call that reference range, they're within the reference range. I can't explain why you're still fatigued or why you have, I didn't put, I don't think there's brain fog on there, but that's a common complaint. That woman will come in and say, I've got brain fog, hits me usually 2 o'clock, 3 o'clock in the afternoon. And this is even with folks that might be on some thyroid replacement therapy. And so, I explained to them what we do differently, why we're looking at not just TSH, but T3 free, T4 free. And we're not just looking at reference ranges. We're going to work on getting folks into the optimal level or optimal range. And then when we do that, and it's usually within weeks of seeing them back, 6, 7 weeks, they'll come back and go, yeah, that brain fog is gone. That fatigue is gone. So it makes a huge difference. And then it's fun to look at how they're feeling and then compare that with where their labs fall now.
Awesome. Yeah. Amazing transformations. Yeah. There are a lot of stories like that when women have been on especially women, like you say, they've been on the same dose of thyroid for years, but they don't feel good. And then you
Right.
put them on some T3, which we're going to go into a little bit of that later in case studies, and they feel better. So symptoms of males, and I will just say this, and this is not a sexist comment at all, but males are just, for obvious reasons, males are just so much easier to treat with hormones than females. Now, it's not that men don't have estradiol. It's not that men don't have progesterone. It's just that you usually just don't have to focus on those. Men can have hot flashes, but they don't that often. Usually, what you see with men is decreased libido and decreased energy and weight gain, especially around the middle. Those, and we could have added erectile dysfunction on here too. Those are all things that if you see those in a man, high cholesterol, erectile dysfunction, weight gain, you see any of those, decreased libido, you see any of those in a man and they're in their 40s, don't think that they need Lipitor. Don't think that they need Viagra. The first thing you should think of is fix the problem. Those are where the symptoms are. That's what's causing the symptoms. So you have any insight there, Karl?
Yeah, probably, again, the same thoughts that I have is men are, they're more simple creatures. And so for the most part, 90% of the male population I work with, they're, once we get them going, they're good to go.
Great. Next slide, Lindsay. Okay, so I'm going to go ahead and let you kind of take over, Karl, on this and just talk about, what initial lab review looks like in women.
Right. And so, keep in mind, and I don't know the exact audience that I'm looking at or teaching to, so you'll know them better than I do. But, again, you're getting a typical history, finding out, what's going on with that particular patient. So there might be a few things you would add or subtract from this, but this is a usual women's panel that I'll get, the complete blood count, the CMP, vitamin D. I think you addressed that with our last seminar a month ago, vitamin D levels. I can't remember if we did or not, but I always, talk to my patients that, wow, that's the natural happy hormone, the natural anti-inflammatory, the natural anti-infective. And I just can't tell you how many patients I've seen with vitamin D levels in the 15, 18, 20 range when really they should be 70 to 100 if you, call that more the optimal range. DHEAS, get that on both men and women. Again, that has to do with your adrenal system. And I think we talked about that last teaching seminar, just that the adrenal system kind of overrides everything. Then you've got the endocrine system. So if the DHEA isn't where it needs to be, then we need to make, we need to make corrections there. Lipid panel, always nice just to get that baseline because it's also fun to see what happens once we start to correct the cholesterol by actually optimizing hormones, the vitamin D, optimizing thyroid. So then we check TSH, free T3, free T4. I do like to draw a little diagram and do some explanation as to why I'm doing the free T3 and free T4. And again, Shawn, you addressed that last month with just explaining kind of the one being the active metabolite, the other one, T3, is your more active metabolite. And then I like to look at progesterone levels. And again, there's reference versus optimal. And then I don't always do microalbumin creatinine ratio, but I do like to add it in there because it is probably the most sensitive inflammatory biomarker based on the Framingham heart study, but it's still so underutilized. And so when I look at that number, I'm looking at more fine-tuned numbers, meaning for a female, I like to see it at 7.4 or less, and for a male, 3.9 or less, where the cutoff range is 0 to 30. But again, the Framingham Heart Study has really pulled this one out as one of those independent biomarkers for inflammation.
So basically lower microalbumin and you have less inflammation.
Correct. Doesn't tell you where, in that 60,000 miles of arterial lining, but at least if it's elevated, then for me, it just kind of indicates, okay, there's inflammation, and maybe some of the treatment that we're going to work towards today will help reduce that inflammation.
And remember, on vitamin D, we didn't put it in there, but it's vitamin D3, and the best way to measure vitamin D3 is 25-hydroxy vitamin D3. So, because that's the one that stays in your body for a long time. So remember that when it comes to vitamin D3. And if you want any more specifics, please, you can refer back to last month, I believe, or we have had a presentation on vitamin D, but we can get you that information. So email Lindsay and she can get you that information. Go ahead, next slide. So go ahead and continue, Karl, with labs female.
Okay, so may add additional labs. Again, just it's based on their history, fatigue, unusual amount of menstruation or heavy amounts. Then I'm going to check total iron binding capacity, which will include their ferritin level. It's not uncommon for me to see ferritin levels in the 10, 16, 20, maybe 30s, but again, I like to see that closer to 70 to 90 for optimal. B12, again, there's reference ranges, and I like to see that on the higher end, closer to 1,000, 1,100. So it's really based on the personal history that I'm obtaining. So I don't always get those labs, but I'll listen to kind of what they're telling me. And then we use genomic DNA testing through GX Sciences. That has been actually probably the best way to personalize and individualize a nutritional program for these patients. Again, one of the things that we do try and do is when we're integrating and doing really more functional medicine is you want to be able to optimize some of those nutritional deficits, which again is going to make the adrenal system work better, the endocrine system, and you have all these things working in synergy. Makes a huge difference for the patient.
Absolutely. So we do have a question, Karl, from a viewer. How much does the genetic testing cost?
Let's see, if you go to their GX Sciences website, you can see the various testing that they provide. There's neurotransmitter testing, there's vitamin testing, but I'm trying to think off the top of my head the cost. I want to say the low end, depending on what you're getting, could be as low as 174 to the high end, saying somewhere in the 320 range. And it just depends on how extensive the testing you want to do. I feel very confident about this company. I've met the founder, the owner, Dr. Stewart, and actually have had several of my patients from the Wenatchee Valley area that actually have been seeing him since 2013. They fly down to Austin, and then they found out that we're doing this same type of genomic testing up here. And so now they're kind of staying put rather than heading down to Austin.
That's awesome. All right, let's go ahead and move on. So let's go into males now. So go ahead and go through this, Carl.
Yeah, so again, males for the most part, as we talked about, are more simple creatures, and um, I still get some basics, CBC, CMP. I do look at their vitamin D. Even with some of these men that come in, they're tanned, they're bronzed from being out in the sun all the time, and I'll check their vitamin D levels and still find that they're not optimal. Maybe they're in the 30s, and again, I like to push that vitamin D level 70 to 100. There's even one study. I got one slide in my slide presentation where vitamin D levels in the 70 to 90 have been shown to reduce colon cancer. So again, baseline D there. DHEA, same thing with, again, women and men. You need to correct those adrenal system. And one story I have on that one is this gentleman came in and 35, something like that, and wanted an antidepressant. He said, I'm depressed. I need something to help. And he's not necessarily one that I would be putting on testosterone. Still, he was married, still wanting to have kids, so didn't even approach that. But looked at his DHEA levels, and again, men should be 400 to 500 optimal, and he was sitting at 60 or 70. Started replacing that, and within weeks, his depression went away, and he was feeling great. So that's a nice little example there.
That's
Lipid panel,
yeah, amazing story.
yeah, testosterone, and again, I try and stay free and clear of the gym rats. So, 40 and under, I generally am not going to be testing their testosterone unless there's other issues that are rising to the top. Same thing, TSH, free T3, T4. We talked about the microbiome creatinine ratio being a good baseline inflammatory panel. And then I do like to check their PSA. And then other labs are based on history. But again, I like to do that genomic DNA testing just to find out where their nutritional deficits are. Estradiol. I don't typically check this, again, unless it's reasons for research. Now, I know earlier on when I was doing this kind of hormonal treatment, testosterone, I think the big thing, and Shawn, you can pipe in on this, is estradiol is considered evil for men or bad, right? Um, and so, we talked many years ago about aromatase inhibitors, or how to prevent that conversion from testosterone to estradiol. And now there are so many benefits to estradiol even for men, and there's been some discussion about, okay, maybe estradiol levels at 70 to 100, which is the same level you would be at if you were a 20-year-old male. But I generally don't check it unless there's an issue or perhaps I'm doing research. So not one that comes up.
Yeah, my opinion of estradiol is just that, Carl. First of all, I think, testosterone does aromatize to estradiol, but I think it is worse when you have high peaks, like with injections and if you do transdermal. And, speaking of gym rats, I think that it's got a little bit overblown because of gym rats. So for, your listeners and viewers out there, what that means is if you have a 40-year-old or less male come in and they talk to you about what they want you to prescribe, like they want you to prescribe testosterone injections, and then they want you to prescribe an aromatase inhibitor with it, or an estrogen blocker, they'll call it. My thing is, stay away or be careful. You want to be really, really careful with those patients, because there's a saying, Carl's heard this before too, because he got trained the same place I did, that what happens when you feed the stray cat, leave the milk out for one stray cat, all of a sudden you have 40 stray cats. So be very, very careful about that. So I'm with the opinion of it on estradiol also. What most people don't realize is that men have an estradiol ratio, a level of like 50 as a baseline in their 20s and 30s. So I don't see a problem with estradiol. So now if they are getting kind of camastia, maybe there is an issue, but a lot of times that's a weight issue too, because you store a lot more fat when you are overweight. So that's probably a whole nother issue. So I'm sorry, you store a lot more estrogen when you're overweight. So that's probably a whole nother issue. So yeah, thank you for that, Karl. So what about thyroid in men? You must check that too, correct?
Yes, so yeah, so that's up there in that TSH, free T3, free T4, because again, if we're going to see elevated cholesterol, we know the benefits of optimizing their T3.
Awesome. All right, I think so. Go ahead and hit on this a little bit about lab review, Karl.
Yeah, so again, you get their labs, and it's not that the labs drive everything, because it's really based on their symptoms and combining looking at their labs, and for some of my remote patients, I see them one time in office, and then we might set up a Zoom meeting or a FaceTime meeting to go over labs and kind of determine or lay out a plan. For women, I definitely let them know that this is not going to be an easy fix. Again, we've talked about men being more simple. Women are just, created differently, more complex in terms of the things, the hormones going on and the endocrine system. So I kind of give them up front. It may take up to a year. If it's a lot less, then great. But if you let them know it's a whole year, then they're not feeling bad if they're 6 months into it and they're still kind of struggling. For men, 3 to 6 months, but really my experience has been, oh my goodness, you just turn that dial and you get them going, and you don't see them or hear from them until it's 6, 8, 9 months down the road.
Yeah, men are a little bit easier. I usually tell men 8 weeks and they'll be feeling pretty good.
Right.
And many within a week they'll report back.
Oh, especially if they're especially if their thyroid, or not, well, even if their thyroid is in the basement, but if their adrenal system is in the basement, if their testosterone is in the basement, meaning I have one gentleman, I was looking at labs here where the testosterone was 38, and so within weeks he was feeling great.
Yeah, of course.
Right. So 8 weeks. Again, I don't, that's typically for if I'm starting folks on thyroid, trying to optimize their thyroid. I really look at doing mostly just checking the free T3, because I want to optimize that thyroid. And I just saw a question here from Matt. What is the upper limit of testosterone that you will titrate to? So testosterone is not, once I determine that they're low, it's not something, even if they're feeling crummy. Okay, so with testosterone, I don't really, once I determine that they're low, I don't recheck it as a general rule.
And let me, if you don't mind, Karl, I'm going to reiterate. I'm going to go ahead and reiterate on that. Is that okay?
Yeah, go ahead.
So I know that sounds really, really crazy, but here's one of the reasons why. It's important to know what labs you're checking and timing of the dose versus when the lab draw is. And if you think about what a lab draw is a small, very small snapshot in time. I will get this question from providers quite commonly. I'll get a question like, well, this guy's testosterone is 1,300. We got to take it. That's way too high for this guy. And I'll ask, well, how are they feeling? And they'll say, oh, he feels great. No acne, no oily skin, no aggression. He feels better than he's felt in years. I'll say, well, don't change anything. But some people get really, really conservative, and that normal level in a total testosterone is anywhere from 250 to 800, let's say. So it's outside of that range. So what I will remind those practitioners is, well, if you don't want it to be high, then tell them to not use it that morning. And if they're applying their testosterone once every morning, don't use it that morning. Get their blood drawn and then apply it afterwards, and their level will be back down to like baseline. So it'll be like 300-400, and that'll make you happy. So you basically what Karl is saying is you just you can't chase lab levels, and so sometimes it's just better to not chase them. You know clinically what is going on, and it's really it's really hard to get, as long as they're going through their refills appropriately and they're not overusing the cream inappropriately, which with the cream, it's harder to overuse than it would be an injection. So that's kind of what Carl's alluding to there, and why he doesn't check. If you do check, just be ready for for the action if you want to take an action. So if it is too high, realize if it was drawn, the blood was drawn an hour after using their testosterone, it's going to be high. If you don't want it to be that high, then wait 12 hours. So just realize what you're going to do with that test.
Yeah, and it's somewhat protects you too, because again, there's still a number of folks out there that feel that testosterone causes heart attack and stroke, and that has just never been a cause and effect find at all. But if some event takes place, they're going to go looking at your labs and go, hey, their testosterone level was high.
Right.
And again, back to what Shawn said, it's like, well, when was that drawn? You have all those issues. And then the other thing that happens from a physiological standpoint is testosterone is only going to fill so many receptor sites. And then once those receptor sites are filled, it gets converted to estradiol. So you can have that isolated high level, and really what does that mean? So it's back to symptoms, back to skin, all those other things.
Absolutely.
And then, yes, so again, with men, it's stable, follow up in a year. That's with men. It's, again, pretty routine. But women, it might be every 3 months in that first year.
So case studies. Go ahead, Karl. This is a great case study.
Yes, so 31-year-old female with a history of PCOS, diagnosed when 16. Had a history of fibrocystic breast, painful, debilitating periods, acne, moody, no sex drive, fatigue. Getting pregnant was challenging, but eventually was successful. Had been on birth control, but is no longer taking, and now wants to do something more "quote unquote" natural. Has been seeing another clinician and getting some help, but not where she'd like to be. Goals for this patient with PCOS, and this is in general for PCOS, is you want to optimize their thyroid progesterone levels along with reducing insulin resistance, or IR. This person is taking NP thyroid, 2 grains or 120 milligrams every morning. Next slide. The labs that she brought in, TSH had not been done, which is fine. Again, I think she came in from someone else. Free T4 was 1.42. And some of the other work I've looked at, besides taking the bioidentical hormone replacement therapy, is Dale Bredesen. He's out of Southern California. He's done a lot of work on preventing Alzheimer's. And so he'll talk about optimal between that 1.0 to 1.5. Her free T3 is 5.59, which again, most folks might freak out about that, but a lot of the work that I've looked at says that optimal range is 4.4 plus, or 4.4 to 6.6. Her estradiol, again, I don't typically check this for pre-perimenopausal females unless we're doing research. We want to just track it, but it's not something that I typically do. I will for my menopausal females. Her adrenals were good at 223. Her progesterone was actually pretty good, close to that, really that range, that optimal range of 10 to 21. Just wanted to confirm that she really had not been given a definitive diagnosis of PCOS. It was just what she had heard, but did an FSH. It was 1.5, LH 1.6, so that's a 1-to-1 ratio. Typically, you're going to see a 2 or even 3-to-1 ratio. So she was definitely either in the process of flipping, or just that's kind of where she's been. Her ferritin level was 67, so close to optimal. So really, at this point, levels that weren't too bad when I inherited her. So she had already been making some good progress. Next slide.
And so if you don't mind me adding some things there, Carl, one thing that you'll notice is that free T3 of 5.59. I can honestly tell you, at least the patients we see, because normally we see patients that have fallen through the cracks. Normally, the only way you would see a free T3 in that high of range is if they're taking free T3, if they're taking T3 of some sort, like with Armour Thyroid that she's taking or the NP Thyroid. So it's just a note that, watch for your patients when they're on levothyroxine only, because those free T3s will be in the twos almost invariably, at least for the patients that are falling through the cracks and the normal ones that I see. And again, what Carl was saying about the estradiol, it's kind of worthless to check estradiol in a premenopausal woman because it only check estradiol postmenopause because it is going to invariably be normal or high, as it is in this case. Another thing I want to say is the progesterone level. And, Carl can add on to this if you would like. Progesterone in somebody that is cycling especially, it is all over the board depending on where they're at in their cycle. So their progesterone might be normal when you check their blood that day, but remember what a blood test is. It's a snapshot in time. That doesn't mean that she's not going to have low progesterone symptoms at different times of the month. So remember, labs are a tool to go along with symptoms and history.
Right. So
go ahead.
Next slide. And again, Sweet Gown, I'm still working with her, and because of the COVID-19, we kind of fell off a little bit on getting her back in, but she's coming back in. And so the plan was to remain on the NP Thyroid. Thought that was great. She's doing good there. Went ahead and added progesterone, 100 milligrams sustained release at nighttime. Metformin to really help reduce the insulin resistance, and then said, let's get back in, recheck labs 8 to 9 weeks. Also talked to her about eating a non-inflammatory diet, intermittent fasting, 18-6 or 16-8, and that's based on a lot of Dr. Jason Fung's work out of Toronto, Canada. And this gal actually was already up to date and really well ahead of the curve in terms of knowing about non-inflammatory foods and intermittent fasting. Came back in second labs, again, free T4, free T3 were fine. She was still complaining of low energy, no sex drive. She just simply could not tolerate the metformin. Her progesterone, this time the window in time we caught her at 1.04, and she was still having weight gain in spite doing all these things, intermittent fasting, routine exercise. So again, a reminder that I'm giving you probably the most challenging case that I've had. So I've had the bell-shaped curve, and she's falling outside the bell-shaped curve. So I don't want to discourage you, but she is a tough one to work with, but easy to work with in terms of patient-wise, and she knows that she is going to be challenging just because there's so many variables coming into play. Okay, next slide. So had her adjust her NP Thyroid, and this is something that has worked well, is you just have them split it. 120 in the morning and 15 milligrams at 2 p.m. And again, doesn't work well for everybody because trying to remember that dose at 2 p.m., especially she's a mom of kids, but she felt that she could do it. She was having some brain fog. I increased her progesterone to 200 milligrams, and I stopped the metformin. Had her start acrobose, which is mostly a medication used in European countries. It's still in the U.S. Just to see if we could have a better results on her insulin resistance. She was not able to tolerate the metformin. Problem with this medication, it still has GI side effects such as increased flatulence. So, just gave it to her to see what we could come from that. Testosterone cream, just to see if we could kind of increase that libido, that because I don't know if the labs are there, but her testosterone was definitely low. And then we asked her to come back to, check labs, but again, due to the COVID-19, not able to get them. So hopefully next week we'll be seeing where she's at. But I've been in communication with her, and she's actually feeling better. She just wants to find out where labs are. Next one is this is probably one of my most favorite patients. Saw her in 2018, still a patient. And her history was pretty amazing in that she had this long-standing history of abnormal pain, irregular periods, including episodes of heavy flow to the point where she was not able to even leave the home for a day or two, or sometimes up to 3 days. She would become so debilitated to the point she had to stay in this darkened bedroom. Husband would have to come home from work to attend to their young children. And her periods were every 30 to 35 days. She had suffered acne throughout her adult life, and was just absolutely miserable. And as you can see there, one point could not even climb the stairs. Wow. Also has a history of anxiety. She says she overall sleeps well. So she comes in for her labs and checked her micro 1.3. Lipoprotein A, I do check that every once in a while because that's another inflammatory marker. Cholesterol HDL ratio, all good. Her free T3 was, on the lower side at 3.3. Her ferritin was low at 31. Again, optimal. I like to see that closer to 70. Progesterone really actually looked pretty good at 14.5, when I, again, have seen optimal somewhere between 10 and 21, but also recognizing I'm capturing her at that moment in time. Adrenals are fairly decent. Again, I like to see DHEA 200 to 250. Vitamin D definitely low. FSH-LH ratio 2.5 to 4.9. So this is flipped. Again, you want to have it at 2 to 1 or 3 to 1. So for me, I was able to confirm to this gal that had been suffering. I mean, really, 28 is when I first saw her, and she had gone through all these years, 21 to 28, of missing 2 to 3 days of her life every single month. And she'd never been diagnosed with PCOS. So that diagnosis, plus the low vitamin D, low ferritin, and anxiety. So wanted to give her vitamin D, wanted to go ahead and bump her up and give her 10,000 for that first month, and then bump back down to 5,000. Start on Nature Thyroid. Again, the importance of taking down an empty stomach. I think most of us are aware of that. I learned recently that even taking it with minimal amount of water helps, because again, the water minerals can interact with absorption. Is that your understanding as well?
Yeah, I never thought about mineralized water. I guess if you were drinking, because minerals for sure will decrease absorption. So I never thought about mineralized water, but unless you had distilled water, it probably would be a good idea.
Right, right. Had her take a B complex once daily in the morning. Next slide, please. Farrow food, which has iron in it. I get that from standard processing, but folks have their comfort level of what type of iron they're using. That's fine. In her case, I started her on progesterone 50 milligrams rapid dissolve troches. And the reason for that, I have found, is in her case, if you remember back to her history, she sleeps well, but anxiety was part of her history. And so giving it rapid dissolve during the day or in the morning really helps calm her anxiety. And what I wanted to do was, instead of a once daily, I said, okay, let's figure out that 14-day window, and we'll start at that point and then see how you do. And again, give her the option to increase to 2 daily if needed. I also happen to use, I have a nutritionist that I've worked with, and so she kind of recommended pituitropin twice daily and hypothalamus. These are both supplements from Standard Process. And in speaking with this nutritionist, Amy Duncan, she said, well, this will help with reducing that LH-FSH ratio. And I've had good response from this patient. Third visit, patient is here for follow-up. She's doing well, has noticed appreciable difference with her anxiety in taking the progesterone, noticed a significant calmness that she's never had. She does increase it during her cycle, and this has helped tremendously as well. She's on her period. It's still heavy, but it's only 2 days during the month. But she's no longer actually, off the slide there. It's like she is just someone that I picture just absolute beauty and happiness, because suddenly she gained 2 to 3 days of her life back each and every month. We checked her labs, and free T3 still sitting at 3.3, ferritin at least bumped up a little bit. FSH, LH ratio didn't really adjust much, but her vitamin D did increase, and her progesterone is now sitting at 20. So had her increase her ferrofood to 2 daily, and or could switch to a different non-iron-based supplement. Next slide. And then I was just talking with a patient a couple of days ago. She's happily pregnant with her third child, week 32. And her midwives did take her off progesterone end of the second trimester, which is pretty common to have that happen. And in her case, I talked to her about maybe putting her on progesterone at the time of birth to prevent postpartum depression. Absolutely. But she said she would definitely be in touch with me as she gets closer. Okay, then we have the male, 68-year-old, no energy, no sex drive. He's wondering if he should have his testosterone checked. Concerned with issues of prostate as well, concerned about testosterone and will it increase his risk for prostate cancer. Shawn, do you want to talk about that a little bit?
Yeah, I might let you discuss the science of it a little bit, because I kind of am a little cynical sometimes when I talk about it, because I've been doing this for 20 plus years now. And 20 some years ago when we first started doing it, there was a urologists were like, oh yeah, testosterone causes prostate cancer. Let's not give testosterone because it causes prostate cancer. And in my opinion, it made no rational sense whatsoever. I thought, well, let's see, who gets prostate cancer? Usually men in their 60s, 70s, 80s, and sometimes a little bit younger, when their testosterone is, definitely declining for sure. If prostate cancer was caused by high testosterone levels, then how come 19-year-old men don't get prostate cancer? So, and I could debate that subject for a long time, but if you want to, that's just my rational thought. It has the same thing to do. My thought is the same thing when it comes to testosterone causing heart attacks. If testosterone caused heart attacks, then 19-year-old men would be having heart attacks. Now, just to say, association does not prove causation. So just because somebody's on testosterone does not mean it caused a heart attack when they were 70, or does not mean that it caused prostate cancer. So if you want to, go from there on to some of the science, Karl, and what you do in clinical practice, I would appreciate it.
Yeah, no, it's there's never been a study to show that there's a cause and effect exactly. And so here is the protective effect of when you're taking testosterone supplementation. And back to, I talked about the receptor sites, so from a physiological standpoint, there are only so many receptor sites. Once the testosterone fills those receptor sites, it gets converted to estradiol. Estradiol has been found to have a protective effect against prostate. And I actually have a patient that I'm giving both testosterone to and estradiol to, but he's post-prostate cancer treatment. And it's quite fascinating to watch. I just kind of titrate his PSA to 1.0 or less based on giving him testosterone and even supplementing him with estradiol. Not something I'd recommend for folks that aren't seasoned or have the training under their belt, but have had great success with that. In this gentleman, we did, okay, I'm going to actually step back a little bit. So the challenge sometimes is, in this case, I use Cleveland Heart Labs because Cleveland Heart Labs will take Medicare, Medicare patients that we see versus we'll use Quest Labs. So you have to kind of go back and forth between Quest or LabCorp or CHL, Cleveland Heart Labs. So their testosterone free is a different assay that they're using. It's 7.44. And so again, if someone else is seeing this patient, they go, well, your testosterone is within range. You're fine. You don't need it. And really, I'd like to push him closer to 25. TSH was good. T4 was normal. Free T3 was low at 2.6. Again, optimal is that I like to see it as 4.4 to 6.6. PSA 3.25. All other labs were within normal limits. Okay, initiated testosterone 200 milligrams per pump. Apply once daily to scrotal sac. You'll notice that actually most times, Shawn, when you've sent out testosterone, it's applied to the shoulders, but the scrotal sac really is the best absorption site. And you talked about that at your last session as well.
Absolutely, yeah. We actually have a study to show, we know clinically what was going on when we would have patients apply it scrotally. We knew it was being absorbed and what their levels were reaching, but we never had a study until we, about 2 years ago, we did a case study to show how it's absorbed and maintains good, adequate levels for up to over 12 hours, actually. So it's a great way to deliver testosterone. And you have less risk of transfer to somebody else than if you were applying it to your arm and shoulder area.
Right, right. Initiated natural thyroid once daily. Rechecked his labs. Again, men are so much easier. Free T3 is 4.2. And then I don't routinely check testosterone. Just, we talked about those in the previous slides. Patient doing very well, restored his energy level, increased his sex drive. He had lost weight, gained muscle tone. And like I said, in general, men are much easier to manage. One of the things that, actually, before I go on that next slide, that I do want to address, and I didn't put in these slides, is when you're talking with men about the benefits of testosterone, there's usually like 11 points that I'll go through, and I'll do increased libido as the last one because, I don't want his wife coming running at me pissed off because, I've increased his sex drive. So I kind of put that as the bottom list. Or it might be on the top of his list, but I don't want the spousal units really mad at me. Okay, next slide.
And on that, Carl, Matt Dinsmore had a question. Will you pull that question up? I don't know if I can see that. I think it's aromatase inhibitors. Is that the last question, Lindsay? Will you just, is that correct? Yeah. And I don't think we answered it. We answered it earlier, but he went ahead and asked it again. So what about men and aromatase inhibitors? Let's go ahead and say that really quickly again, Carl.
So yeah, so that used to be the previous kind of theory is, boy, we got to eliminate estradiol and its harmful effects. And really what we've found is estradiol has good cardiovascular protection. Estradiol can lower cholesterol. Estradiol is good for bone health. Estradiol is good for the health of the prostate. And so unless someone is getting, breast tenderness, breast enlargement, which we really don't find with the use of bioidentical cream, we're not using aromatase inhibitors. Hopefully does that help, Matt? Okay. So this patient recently inherited, 89-year-old female with no energy, restless leg syndrome, interested in hormone replacement therapy, brain fog, simply no longer enjoying life, so quite depressed. Attempted for years to have her doctor from Spokane adjust her thyroid and place her on hormones. She's been experiencing hot flashes, some depression, and the common, some of the elderly patients and even my younger patients, it's amazing that what they get from their physicians is, hey, you're old. What do you expect? And all your labs are normal. This patient was already taking levothyroxine along with the medications for blood pressure.
And just so I can go on a sideline of that. So, here's this patient she's 89 years old. She's on thyroid already, and she's on blood pressure medication. So when we talk about how long should somebody stay on hormone replacement, well, how long would that doctor keep her on blood pressure and that thyroid replacement? So if we want her to feel better and we can make her feel better with some estrogen and progesterone, why wouldn't we do that? Same thing. Let's think about bone density. That's the thing why when I talk to patients, how long would a doctor keep you on something for your bone density? Well, probably for the rest of your life. Hormones, I believe, should be no different. Now, that's a very personal decision between them and their prescriber, but those are my beliefs. Go ahead,
Right.
Karl.
So, even so labs, again, I can understand, her physician was looking at TSH, T4, T3. Hey, those are all normal. You don't need anything. Her progesterone was non-existent, which, again, you expect to see that in someone who's menopausal. Her estradiol 16. Cardiovascular protection, bone protection, brain protection. I like to see that estradiol 70 to 120, and that's again based on some good reference data, some of the hours I've taken at these lectures. Her adrenal system, actually pretty good for her age. Would like to see her closer to 200. Vitamin D, definitely in the basement. And I think I saw her pre-COVID days before that all started. So definitely got her started on the vitamin D 50,000 once weekly. Thankful I did, just because, again, there's great protection there for any virus. Starter, in her case, let's go back to number one, liothyronine. Normally some of these patients, I'm going to start them on a nature thyroid or NP thyroid or compounded thyroid. Because she's 89 and because you're dealing with, again, someone aged, you want to make these tweaks and changes in kind of minor increments. So I kept her on her levothyroxine and just asked her to add liothyronine or straight T3. Started on progesterone and started on the BIES 0.51 milligram. And then DHEA 10 milligrams once daily, just to kind of boost up her adrenals just a little bit. Go ahead. Returned last week with her daughter, just feeling absolutely wonderful. Not always good at remembering her morning liothyronine or her nightly progesterone, but overall her energy and stamina had improved. Came back with her TSH, free T4, free T3, still not where I wanted to see it, so probably a big indication that she's not taking that liothyronine as scheduled. Progesterone, again, she admitted that she wasn't always good at remembering that, but she was definitely good at taking the BIES because her estradiol was right where I wanted to see it, and her adrenals had improved, and her vitamin D levels had improved. So the plan was really to have her daughter set up a plan to help her remember medications, specifically liothyronine and her progesterone, and then we'll plan to recheck her again in 8 to 9 weeks. But on a personal note, oh my goodness, she was doing tremendously better, even with making some of those minor changes.
That's just an awesome story. Well, thank you for going through those, Karl. Those are great stories. And what I like to say about those stories is those are not unique. I know we hear about those stories all the time in our pharmacy, at least daily. We have a patient's life that has been changed by somebody like Karl, who has balanced somebody's hormones. So does anybody have any questions? You can send it in the chat, or you can unmute yourself and you can ask the question. We would love to answer any questions if you have anything. If you don't, you do know how to get a hold of us. That concludes our CME presentation. Make sure you stay in touch with Lindsay so you can get credit for this, and make sure you give us feedback about what subjects and topics you would like to hear about next time, because I think it's September 30th we'll have our next one. We're going to go on break for the summer, but we would love to see you in September. So ask us about, give us feedback and let us know what subjects you'd like to hear about. Other than that, I think we are finished for the day. So thank you so much for listening, and keep in touch. Oh, Matt has a question. What's the question? Did we answer that? Estrogen blockers. I think we answered that, Matt. But we don't typically use them when you're using transdermal topical testosterone. You don't typically need them. There's many benefits of estradiol. Men need estradiol just like women do. It's good for many different things. So typically, unless they're getting gynecomastia, we don't traditionally use estrogen blockers like aromatase inhibitors.
Yeah, I haven't. I don't remember the last time I used it. In the last conference I attended, Matt, they were
there's another prevention wellness hormone conference, another group out there, and I think the founder of that group, it was probably 2 years ago, had a heart attack, and a massive heart attack, and died. And he was a pretty fit, robust, physically fit gentleman, and ended up having this massive heart attack. And he was big into aromatase inhibitors. And I think even that organization has now stepped away from the use of aromatase inhibitors, again, not wanting to block all the benefits of estradiol.
Absolutely. That's an interesting story. That's good to know. All right. With that, we'll conclude our presentation. Please stay in touch. Thank you so much.
All right. Thank you.